So we're still on the part where we're reviewing things that you learned last year in pathophysiology. So we talked about the normal heart function, and now we're going to talk about categories of heart disease or heart dysfunction, and how you're going to end up in cardiac rehab. So the four main classifications of heart disease are vascular, having to do with the venous arterial system, valvular, having to do with the valves in the heart, electrophysiological, having to do with the electrical impulses, or cardiomyopathy, having to do with problems with usually the coronary circulation or the myocardium. So classifications can overlap. It's not like you just only have one of these. You can have all sorts of interesting combinations. So electrical abnormalities can be caused by circulatory issues. Cardiomyopathy can be caused by any of the other three or can be a standalone problem. Other issues can cause electrical abnormalities like electrolyte imbalances, particularly potassium imbalances can cause electrical abnormalities in the heart. So it's not just one thing, and a lot of times you're dealing with multiple things with someone who has heart disease. So just in general, and if you recall from modalities class, there are a lot of things that were contraindications for people with heart disease. So bear that in mind with your treatments as well. Someone can have any one of those things, and it's going to change how you're going to treat them in the clinic. So complications of coronary artery disease. Angina pectoris means chest pain. And you can think of angina being a temporary obstruction to blood flow in the coronary arteries, and myocardial infarction being a long-term or a longer obstruction, which causes heart damage. It's exactly analogous to a TIA versus a CVA. So a TIA is a transitory obstruction to blood flow in the cerebral arteries, and a CVA is where you actually get enough blockage to have cell damage. So angina is obstruction to the blood flow in the coronary arteries. There are categories stable and unstable. Stable angina has a predictable cause, timing, and intensity. So the patient knows what causes it and they know how to stop it, basically. Unstable is an unpredictable cause, timing, and intensity. It can be refractory to treatment. It can worsen in time with severity, frequency, and duration. And it's treated by medication. So people take nitroglycerin. A lot of people with angina keep a little either a pendant or something with a little nitroglycerin tablets in them, and they take them as needed. So that's its main treatment is medication, but we have to know about it because unstable angina can be a contraindication for exercise. Myocardial infarction, this is the analogous to the stroke where you have a complete blockage. So you can think of angina as being partial temporary blockage, and myocardial infarction is a complete blockage of a coronary artery. So 25% of cases of myocardial infarction end in death due to ventricular fibrillation. So ventricular fibrillation is serious. Well, it's all serious, but in myocardial infarction, you can have ischemia, which is an obstruction to the blood flow in the myocardium. It can be temporary and reversible if there's not too much cell damage. So ischemia, is lack of oxygenated blood. And infarction is where the blockage leads to death of myocardial cells. The degree of damage from partial muscle thickness to massive. Okay, so you can have a really tiny myocardial infarction or a bigger one. And of course, the layman's term for myocardial infarction is heart attack. The treatment is dependent on the degree of damage. So women are more likely to die from myocardial infarction than men because a lot of the research that was originally done on myocardial infarction was done with men. What's considered to be the typical symptoms are symptoms that men have. Women tend to have different symptoms. So a lot of times women's symptoms are either disregarded by the patient or by the practitioner, the healthcare practitioner, because it doesn't seem like a heart attack. So your classic symptoms of heart attack are the crushing chest pain, pallor, sweating, left arm pain. You know, we've all heard them in CPR classes. Women can have things like scapular pain, jaw pain, shoulder pain, that sort of thing, in what they perceive as indigestion. Sometimes it's just a feeling, sometimes they'll call it a feeling of impending doom, and that's not a good thing. So a lot of times when women report to the emergency department and they're having a heart attack, they go in and they say something's not right. They don't have a specific symptom, but they just feel like something's not right. And hopefully emergency departments are a little bit more alert to that now, but it used to be they just send them home. They'd say, oh, well, there's something minor wrong with you. Sometimes men come into the emergency department because their wife says something's not right with him and they're having a myocardial infarction. So because of the difference in symptoms, women are more likely to die of myocardial infarction, unfortunately. So just be aware of that. And when your patients report symptoms to you, refer appropriately. So congestive heart failure is cardiomyopathy is part of it. You can have dilated or hypertrophic cardiomyopathy. Dilated is coronary artery disease and damage to muscle. Hypertrophic is hypertension and aortic stenosis. So hypertrophic is restrictive. It causes rigidity in the heart muscle. A lot of times it occurs with diabetes mellitus because of increased plaques in the arteries, causing more resistance, more afterload for the heart. So the heart becomes hypertrophied, and that's not good, because you don't want a rigid hypertrophic heart muscle. You want a flexible, healthy heart muscle. Cardiomyopathy or congestive heart failure can be a residual effect from many other cardiac conditions. So it can result from myocardial infarction, valve defects, congenital conditions, or infection. So lots of things can end up as congestive heart failure. Right-sided failure is the failure of the right ventricle to pump blood into the pulmonary artery. And so you get a backup of fluid, basically. And left-sided heart failure is the failure of the left ventricle to pump blood into the aorta and the coronary arteries. So it's bad no matter how you look at it, but you get different effects depending on which side of the heart is most affected. So a lot of times the treatment for coronary artery disease is angioplasty with a stent placement. So stent is like a little cage that keeps the artery open. One of the cardiac rehab people that lectured in this class previously said that it used to be that if you can hold anything down long enough, they'd put a stent in it. But stents are not necessarily the go-to treatment for everything, but it has been a very common surgery and therapy up until recently. Coronary artery bypass graft is, and its nickname is a cabbage, which is the acronym. And so they'll say, you'll see cabbage times 1, cabbage times 2. That means how many coronary arteries were bypassed. So they'll either take a vein or part of another artery, and they'll bypass from the aorta past the blockage into the clear part of the artery. As you probably recall from anatomy and physiology or pathophysiology, Arteries and veins have a little bit different layering, and so arterial grafts tend to last a little longer. Venous grafts tend to be a little more fragile. You will often be seeing people in the hospital after CABGs, and in subacute and outpatient as well. So it's a pretty common procedure, and you're just bypassing the blocked area of the artery by grafting on another vein. So a lot of times after CABG, people are in rehabilitation because they need to recover from that. So we need to know how to assess our patients with congestive heart failure, because a lot of times you're going to be working with people who have congestive heart failure, but they also have other things, and we might be treating them for those other things, but we need to be able to look at their congestive heart failure symptoms as well. So basically the method for assessing them is look, listen, and feel. You're going to look for short, shallow, rapid breaths. You're going to look for peripheral edema or a recent increase in weight. If they will have a preference for upright posture because it's difficult for them to breathe lying down because they have excessive fluid load on their lungs. You're going to listen for crackles in lungs and altered heart sounds. You are going to listen for decreased blood pressure with exercise due to poor response from the heart to activity. So we'll talk a little bit in the next section about what the normal response to exercise is, and we're going to practice that in lab a little bit. But an abnormal response to exercise is something that you need to be aware of. You can feel for edema, you can feel for a weak and thready rapid heart rate, and an altered breathing pattern, dyspnea, difficulty breathing, or orthopnea, which is when you lie them down, they have difficulty breathing. So the treatment is usually, they are usually being treated medically with medications. A lot of times they have medications that are going to increase fluid expulsion. We want to, for exercise, we want to have a slow, gradual progression of activity, slow, gradual progression. We want to focus on aerobic activity and strength, pacing, energy conservation, and breathing. So it's really important when you're working with these people to assess their vital signs on a regular basis throughout the session. So you want to do all the look, listening, and feeling that you can, and really pay attention to your patient's breathing, what they're telling you. A lot of times during the session, it's easy to get so focused on the exercise that you forget about the education on pacing, energy conservation, breathing. So during their rest times, you can be talking about pacing and energy conservation and breathing. So very important in treating people with congestive heart failure. So cardiac conduction dysfunction can be atrial arrhythmias, it can be ventricular arrhythmias. Atrial arrhythmias can be a couple different, well, several different things. Premature arterial contractions, or PACs, can be caused by anything that increases nervous system or neuroirritability, like myocardial infarction, congestive heart failure, or altered electrolytes, like potassium. Atrial flutter and fibrillation. Flutter is 250 to 350 beats per minute. Fibrillation is 350 to 450 beats per minute. That's high, right? So atrial fibrillation is called AFib. It causes a serious decrease in blood volume to the ventricles, and therefore it decreases cardiac output. So a lot of times when you are working with someone, they have a diagnosis of atrial fibrillation, or they'll tell you, oh, it feels like my heart's beating really fast. Okay, you might want to check on that. So atrial fibrillation is serious. It can cause other problems down the line. The other problem with atrial fibrillation is you get pooling of the blood within the atria, and it can cause clots, which can then be thrown off and cause a stroke. So AFib's nothing to mess with. Superventricular tachycardia is an abnormal heart rhythm that arises from improper electrical activity of the heart. It's a type of rapid heart rhythm originating at or above the atrioventricular node. So there you go. So ventricular arrhythmias, premature ventricular contractions, or PVCs, are extra contractions in the ventricles. So you can imagine if the ventricles contract prematurely, they haven't filled all the way, it's going to decrease your stroke volume and decrease your cardiac output. Ventricular tachycardia is 150 to 250 beats per minute. It's usually a single ectopic focus triggering a more rapid rate of contraction. So you get decreased cardiac output. It's life-threatening. Ventricular arrhythmias are life-threatening. They all are. So ventricular fibrillation, 350 to 450 beats per minute, there are multiple foci triggering contractions, and it causes a profound drop in cardiac output. It's usually treated through medical management or by treatment of the underlying causes, whatever's causing that. And we have a handout for the PT that we're doing. Obviously, if somebody's in ventricular fibrillation or atrial fibrillation, that's a contraindication for exercise. I hope that goes without saying, but we'll talk more about that when we're talking about the treatment part.